Thank you very much. So I would request the speakers to come on the stage for the quick question and answer session. Dr. Atif, Dr. Javed, Matt, please. Questions from the audience.
So my question is regarding the marginal ulcers.
Marginal ulcers.
Yeah. So many times when the patient comes with the symptoms of pain after eating, and we do an endoscope, we see staples there. Mm-hmm. What is the significance of that? Is it the same as having an ulcer, or is it not the same as having an ulcer? Number one. And number two, I've had 2 or 3 patients who have had marginal ulcers, then they were completely healed with PPI therapy. It took a long time, 6 months or so, but even then the patient continues to have pain. What do we do with them?
Every time first is about the marginal ulcers. Visible staplers are very frequent. Visible sutures, visible staplers, and some of them they develop ulcers, some others they don't develop ulcers. We don't know what's the material they're using in the staplers, and we have to be very careful because we're using staplers that they say they're titanium, right? Yeah, but everyone is making things cheaper. So maybe at the beginning it's 100% titanium, but now I'm putting 80%, I'm saving something, I'm putting 20, we will never know. And you know that there are a lot of allergies, and our body has allergies in the skin, has allergies inside. So we don't know if that's the reason. But it's true that some patients, they develop ulcers, some others. Having pain and seeing staplers doesn't mean anything at all. Second thing, they have pain. The chronic pain is one of our sins. When we do a bariatric surgery, when we do gastric surgery, you know the albatross syndrome, that legend about the albatross, those patients are gonna be attached to you forever. What do you do when you have this gastric bypass with a left upper quadrant pain that you start guessing? It would be the remnant that is dilated when you are eating because the stomach is there, living, it's alive. And its secretions are there, right? Or is the JJ that is dilating? So those things are, or it's an internal hernia that the patient is having a big gap and is back and forth every time he eats. We don't know. And we will not know because we're not studying properly our patients. We don't have time and we're guessing, unfortunately.
So pain, treat it as a separate entity. So when I have patients come back with marginal things that go through our mind is gallstone disease, post-op, weight loss, consider that nausea, vomiting, nausea, pain, consider gallstone disease. When I offer them surgery, I tell them, this surgery will help you with this, I cannot guarantee pain will go away. You have to treat it as a separate entity right from the beginning.
I'm asking about the patients who have had marginal ulcers, which heal, but then they continue to have pain. So
that's exactly.
And all the investigations are negative.
I had a patient who was cholecystectomy. He had a different pain than gallbladder. So I saw the pouch with adhesion with falciparum ligaments and all those, and I decided while I'm in, let's divide them. The pouch got freed and laid down. And the complaint he used to make after eating, that went away. But that is one case, but I don't know whether for every pain we need to go in and look at whether there are adhesions or not. So, you know, even jejunum if you can create chronic, one of the causes is that if you don't bury it properly, that can also cause pain.
Matt, I have a question. So you said in acute leak, you explore drain, and so is there any role of double pigtail? If yes, in what conditions do you offer that? Endoscopic double pigtail drain.
Oh, endoscopic.
In acute leak, yes. And now this question also goes to Dr. Javed because
actually for acute leak, the most common issue we're asking the GI man to get into help out to check is you could not find the truly perforation site. That's one thing.
Acute sleeve leak, yeah.
Sorry?
Acute sleeve leak.
Yes.
Yeah.
So usually we, if a leak, surgeons get in, use your laparoscope, get in. Usually 99% will try the scope first.
Okay.
So There's some reason the most people do not want to do the open. We keep this kind of a choice, but if possible, we try to do everything laparoscopically. Yes, it is for some matter issue, not only purely medicine. People don't want to have big wound over there,
Okay.
but they want that you definitely resolve their problem. Yes.
Dr. Javed, you once mentioned that double pigtail is...
So in Cleveland, we have a lot of experience of treating sleeve leaks as a team. And we do our own endoscopies and all maneuvers, so we're not dependent on the gastroenterologist for that. We tended to do the mega stents about 7-8 years ago. But now we've moved more towards double pigtails. And sometimes in a big defect, we put two. So internal drainage and nutrition. And if there are any separate abscess cavities, then you drain them percutaneously under PT guidance. So I think even leaks referred from other places, which were chronic leaks, we managed to control them. And in the end, you get them to a clean aseptic state, and sometimes you have to surgically do the final step. But those are sort of lifesavers for us as surgeons. You go into an acute leak, 2 weeks or 3 weeks post-op, it's a nightmare. You cannot touch the tissue. So putting an internal, and I think someone asked me from Pakistan about 2 years ago, they had a leak, and they said there's no stent. And I said, okay, do you have a gastroenterologist who can put it? And it was a mini bypass leak, got better. Because in mini bypass, you cannot put the mega stents. You have 2 lumens. And after that, I think that surgeon's management of leaks changed in Pakistan context because that's affordable thing. So for leaks, please consider or have a gastroenterologist who can do a double pigtail for you.
So,
I think it's a
but
very important
in
tool.
which subset of patients you decide to explore or put in within 1 week of surgery?
We have a case, I think if the video is there, Carlos, you can show. So sort of staple misfire caused leak on first post-op day. We went back in and we stitched it, and luckily that was all that was required. So if it is that early and it's a technical problem, tissue is clean, you can resolve it. 2-3 days post-leak, that's a different situation. That's where you go in and try to drain. And
Septic, yes.
yeah, if the patient is septic, you have to explore, wash out and all that. Even with that, you can put an external drain and put an internal drain. So only one thing, that if you have an external drain with the JJ, then you have to close one of them. Don't keep the external drain on suction, because then you are facilitating a fistula. So this is one thing that you need to be clear about, that if you have a JJ and an external drain, then it's a direct communication to the outside. So block the external drain in that.
Dr. Javed, I have a question regarding suction. Have you any experience of endovac therapy for leaks and chronic cavities, and how does it go in your experience?
So for us, it goes very well. For the patient, not that well, because you have to change that under general anesthesia every 3 days. So it's not for all the patients, it's for big cavities. And that helps a lot to decrease the size of the cavity. It works, but again, it's very tedious, and you have to change that every 2-3 days. And under sedation again, and put the patients with NG, which is very, very bothersome. And many times if you have to do that for 6 weeks.
It's very expensive. Even in Cleveland context, it's very expensive. Okay, in Pakistan context, it will not be affordable. It's very inconvenient for patients. They have tubes sticking out of their nose. Every 3 days you go back in, you change it. It's very labor intensive. It looks good on the papers. Reality, practically, it's good for the ego of the person who's doing it, but practically I don't think it's realistic in Pakistan context. Even in Cleveland, we have done 2 or 3.
Very sick patients, but very sick
Extremely
patients.
sick, when they're dying and we cannot surgically go in and do this. That's one last resort, but it's not a common thing.
Double pigtail is much more 1, 2, 3 double pigtails. You can change them or remove them. Patients are much more comfortable eating from the beginning. That changed completely the scenario. As Dr. Javed said before where wall stents fully covered or partially covered stents, that's not used anymore.
So the only rule stent in that context is if there is a distal twisting, you can put a double pigtail and put a stent to make the system low pressure. That's the only need for
Okay, I have a question to the audience, reverse questioning, because I forgot to mention it during my presentation. How many of you bariatric surgeons experience slipping of the sleeve of the port? And then what do? Sometimes the port comes out during the procedure. What do you do then? And first of all, how many of you use muscle cutting trocars, and how many of you use tissue splitting ports or trocars? Tissue splitting. Even when tissue splitting comes on, especially the optical one, my advice is that usually it's in Trendelenburg position. Make the patient neutral, because when you are placing the optical port, your patient is horizontal and neutral. So reverse the position, take the trocar in and go under vision again. That way you will not convert that tissue splitting into a muscle cutting. The mistake we did that in this case. And after that we became selective. For example, if you are removing stomach from a port side, remnant stomach, that has also been closed with the facial sutures. So this is what I wanted to add.
I go a bit farther. It was a 12.
12 mm,
Port?
yeah.
It doesn't matter, you split or you do whatever, close it with a suture pass at the end of the surgery, and you will not have an hernia.
This is
That's-
what our opinion is different.
Yeah,
Of course.
They're both some selective. There are some who does every closure.
12
some who
ports,
don't do it all.
closed.
Needs to be closed.
Yeah.
So it takes a minute, I don't know, in
And the
rupees.
patient, those who get facial closure have much more pain as well.
It's true,
Remember
it's
that.
true, it's true.
Remember that.
I think upward 8 millimeter should be closed by facial sutures. I think 5 mm will never herniate.
All
8 millimeter.
infra-umbilical, all should be closed.
So I had to do a review about that, and there's a good paper about the 8 millimeter, and this, the incidence of post-op hernia in 8 millimeter is practically the same like the 5.
With the robotic
Practically
arms.
with the robotic arms are the 8 millimeter ones.
Yeah, in the robotic arms.
12, 10, 10, 11, 12, of course 15, you need to close it. Do they have pain? Definitely they have pain. But I think you avoid hernias.
About that external drainage after acute sleeve leak when you are doing operative intervention. So do you use a T-tube for external drainage, or what kind of system do you use for external drainage for an acute sleeve leak when you're doing the operative intervention, not the endoscopic?
So, no, T-tube is only if you want to put it inside the lumen of
Yes,
the, yeah.
yes.
I think it's, if we are doing it, we will do a regular JP drain, and we will do an endoscopic, simultaneously endoscopic double pigtail. That's what, if you're asking me what we will do, if you don't have that, then putting a T-tube is a good option.
So one internal and one external.
So you will
One
put a
inside the
T-tube,
lumen,
yeah.
T-tube,
You will
and
put a
then-
T-tube and you'll put a drain next to it, yeah.
So Dr. Javed, which drain you will remove first? You will remove the external drain first and then you will remove the double pigtails? In what order you will remove them while the patient is healing?
So the
What
thing
has
is,
he-
is right, it depends. So if the patient is septic and you have a leak and you cannot control it, you cannot close it, because now so on the paper it's very easy. You go, you close it, but you get there and it's very messy, and you have to save the life of the patient. You put a drain and you keep the drain there. You don't do anything else. You leave it. And then you consider patient is more stable, the drainages are fine, and now what you want to do is to get a cavity where the double pigtail drains inside of the sleeve. Is what you want. So then you can put the double pigtail and you can start removing if you want the drain. You don't need to remove it completely, but it has to be far from it. Otherwise, you're going to perpetuate a fistula outside. And what you want is different, is that the body pushes everything towards the stomach, not create a fistula from out to outside. So always you need to remove first the external one and leave the double pigtail, of course, inside.
So we don't have a lot of experience of T-tubes, but I have experience with bile duct exploration that I've been doing for a long time. So when I do bile duct exploration, I do put a T-tube and I put a drain. and I remove the drain after the T-tube. Because if it leaks, there's a mechanism to control it. So applying that to the sleeve leak, I would take the T-tube out first. If it leaks, you've got something to control that, and then you can remove the drain.
No, I'm asking about double pigtails and an external drain. So which one, as Carlos said,
Double pigtails, even if it comes out, you can go and put one
no,
again.
no, no. If you want to, if the patient has improved and now you want to remove your drains, which one, in which order you will remove?
I will
them?
remove definitely the external one first.
Okay.
You can separate it when the patient is doing fine, because it's true about the drain, but I think it's a different, the T-tube and the CVD, you leave a drain, because once you remove it sometimes, at least the new T-tubes, because the new T-tubes are silicone ones, which they don't that many reactions. The old ones they were creating, you can pull them after a while and there's no even a drop of bile coming to the abdomen. But it's,
So with this, we come to the end of this session, and for the next session, I will request Dr. Hera Jalil and Dr. Aisha to proceed for the next session.